İndirelim. Bu fotoğrafta şeyler nasıl çıkıyor? Bir şey yazanlar falan.
Uh, there has been a mistake in our announcements since we have written as the European time 1 hour before us, but it is in fact 2 hours. They have changed their times according to the winter time. So Richard will be probably somewhat later, but Ben Reutberg is connecting now, and we can start soon. And Corina is not with us, but Onur is with us, huh? The other moderator is the Onur.
I'm here. So, do we have to
Hi.
start?
Just a few more seconds we can wait, and probably Ben Reutberg get connection, and then
So, Reutberg is here.
did he come?
Yeah. Reutberg is here.
Sorry, Ben.
I just accepted him.
Good, here it's morning, afternoon.
Good afternoon.
Good afternoon.
Welcome, Reutberg.
I must make him co-host. Ben, welcome, Ben.
Thank you very much.
Yeah, how are you?
Very good, thank you. Very happy to see. Yeah, I see you now. Wonderful, thank you.
Yeah.
Great.
Good.
So I have. So I think I'm presenting second, right?
Yeah, but Richard is not connected yet. So probably the first speaker will be you.
Well, very good. So let me share then.
Yeah,
And
actually, first I must introduce Dr. Onur Yaman.
thank
He's
you.
the moderator. And then Onur, you can start.
Okay. So, we have a good topic today. The topic is lumbosacral fusion, when and how. We have very valuable speakers here. Richard Aseker, Ben Reutberg, and Erkan Kaptanoğlu. So, we have to start with Ben Reutberg. He is going to talk when to include L5S1. Ben If you're ready, you may start. Welcome.
Thank you very much. All right, let me get the hold on slideshow. Let me see if now it's better. Do you see it now?
Yes.
Yeah,
Yes.
it's much better.
Wonderful. All right. So that's the topic. Is when to fuse L5S1. So when do we ask this question? Clearly, we're not going to ask the question when there is a clear instability at L5S1. But there is a dilemma when L5S1 does not have an independent indication for fusion, but the high risk may exist for future degeneration due to adjacent segment disease, especially when a fusion at higher levels ends at L4 or 5. You could call it floating L5S1 segment, although some people call the L4-5 fusion itself, when it's isolated, a floating fusion. ASD or adjacent segment disease can occur only radiographically or progress to become clinically significant. So I will start first with a discussion of what's adjacent segment disease. Long-term randomized control studies, including for 10 years or longer, and it's something that I discussed and presented, I found out a few years ago, it shows that fusion accelerates degenerative changes at the adjacent level compared to natural history. The rate of adjacent segment disease after different spinal interventions was similar. We may suspect that adjacent segment disease also reflects natural history of spinal degenerative disease in many cases, or is maybe even a non-specific response to surgical intervention. Clinical adjacent segment disease is less common, and requirement of repeat surgery is actually rare. The annual incidence of ASD requiring surgery was about 1% per year for 10 years after primary surgery. Interesting is those of us who work in trauma centers I have seen, and one of my colleagues, Tim Moore, in my previous job in Cleveland, actually published that ASD was very rare after fusion for trauma in young patients without existing degenerative disease. So maybe it does increase that risk, but if you start with healthy spine, except for a fracture, in the course of reasonable follow-up, you don't see that. So there is no single universally accepted and validated outcome instrument to diagnose or quantify this ASD. We know that ASD can be made worse. So, sorry, I just jumped. Sorry. Yeah, ASD can be made worse. We know that multi-level fusion and facet degeneration are associated with increased incidence of ASD and need for reoperation. So pre-existing degeneration, again, that's the reverse of healthy people who only get fusion for trauma, don't get ASD, but pre-existing degeneration is a risk factor for developing of ASD. In certain conditions, it is significantly more common. So if patients already have spondylolisthesis, and maybe neighboring levels started to degenerate, maybe is at a risk for spondylolisthesis, then ASD does progress faster. And we know that isolated floating fusion ending at L4-5 may actually be associated with more ASD. So the degeneration at L5S1 or subsequent degeneration is associated with long fusion arthrodesis terminating at L5 in patients with adult scoliosis. And a study from 2018, relatively recent, demonstrates that the prevalence of subsequent L5S1 disc degeneration after long fusion arthrodesis terminating at L5 in patients with adult scoliosis was close to 60%, 36 of 67 patients. So clearly, it's a very high rate and higher in those patients where there was pre-existing degeneration. In a different study by Takegami et al. In 23, so really even more recent, they demonstrated that the number of fusion levels was a significant candidate factor for clinical L5S1 ASD. So that's kind of interesting. You see on the right is an illustration of really a very long segment fusion, and you see that L5S1 is not fused there, so it kind of illustrates the concept. So there are some additional clinical considerations here, and we know that there was in posterior lateral fusion a high risk of L5S1 disc height reduction and foraminal stenosis in patients with multiple level fusion. And there was also a large study from the Johns Hopkins group. So Bidon et al., Ziago Kaslan is in the same list. And they followed 511 patients who underwent instrumented arthrodesis for lumbar degenerative disease over a 23-year-old period at one institution. That's not very common in North America because of very high rates of loss of follow-up here. And the follow-up was average of almost 40 months after the index lumbar arthrodesis. And indeed, patients who had floating lumbar fusions were significantly more likely to develop ASD over time than those who had lumbosacral fusions incorporating the S1 spinal segment, but were less likely to experience postoperative radicular symptoms. So it's interesting that there was kind of a price to pay. For some reason, including L5S1 right off the bat, increased the incidence of postoperative radicular symptoms. I'm not sure why. I could speculate, maybe just you add more surgery and you could cause net more complications. We also need to remember that SI joint pathology may develop after L5S1 fusion. It's not the last level. And it could be treated with SI joint fusion procedures. That's a very recent paper. But sometimes you also have very poor bone in S1. And then you need to anchor, as many of our orthopedic colleagues, some of my neurosurgery colleagues do. If it's a very long construct, just anchor it to the pelvis directly. On the other hand, preserving the L5S1 motion segment does not add to function. So it's okay to just add S1 right off the bat, and the patients apparently will not feel, according to a study by Daniels et al. From 2017, they probably will not feel a difference clinically. Now let's go to the short arthrodesis. We talked about the long arthrodesis. How about the short arthrodesis? If you just do L4-5 or L3-4, L4-5. In early studies, like Giseli et al. From 2003, things that influenced me earlier in my career, there appeared to be no need to routinely include the L5S1 segment when performing a posterior lumbar fusions. They followed patients for average of 7.3 years, and we're talking about like 80s, 90s index surgery. And there was neither increased symptomatic disc degeneration nor symptoms necessitating the need for another procedure. A different study, an L4-5 floating fusion, ASD did occur in the patients, and the radiological ASD was more common in the cephalad segment and clinical more common in the L5S1. And again, like in studies before, the pre-existing spinal stenosis appears to be the most influential risk factor in ASD incidence, unlike the cephalad segment. So it's interesting, right? You have different types of adjacent segment disease developing above the L4-5 and below the L4-5 fusion. So is it clinically important? What does it actually mean? Again, lots of studies that look at it from various directions. I think the most interesting one was a finding by Dish et al. That patients who underwent fusions in the segment L5S1 showed lower risk for adjacent segment disease than patients with fusions at L4-5. Right? And bisegmental L4-S1 fusions also showed a similar trend with lower risk for ASD. And to me, what I think about it, my interpretation, is that L4-5 floating fusion had two segments that could degenerate, the one above and the one below. So even in theory, it should result in more adjacent segment disease than fusions where only one segment, the one above, would degenerate. But there was no difference in the clinical results in that study. Again, this is a follow-up time of between 3 to 22 years with average time of 14 years. So it's not a large number of patients, but a very long follow-up. And again, no difference in clinical results. I am still doing, and many of my colleagues still do, an L4-5 single segment fusion, and it's not an automatic indication for L5S1 fusion. Does motion preserving surgery make a difference? A big meta-analysis by Donnelly et al. Didn't show a statistically significant difference in that incidence. They did some weighted analysis, which I tried to understand it, but I apologize, I did not understand what they did there with the weighted analysis. They claim that there is some difference. It's very difficult to reach definitive conclusions, and there's a lot of conflicting reports in the literature, and mostly because fusion that is less rigid or motion-preserving procedures that do stabilization without intent to fuse, but with preservation of motions. There are so many different approaches here that it's difficult to pull them all together into one. I don't think it's valid. I think each one of those approaches needs to accumulate prospectively enough patients with enough follow-up to have its own individual judgment. What about no instrumentation at all? Well, we know that no instrumentation at all may result in fusion at a lower rate than instrumented fusion. But if the fusion happens, then I think it would have logically the same outcome. We know that there is no difference in overall functional improvement, pain-related outcome scores, reoperations rates, or complications rates, amazingly, between patients who were treated with instrumented fusion and non-instrumented fusion. So the fusion rates are higher with instrumentation, but repeatedly. And I was reading this 20 years ago, and in 2022, a review by Hirasa et al. Demonstrates the same thing. So we still are facing the fact that fusion can happen and clinically may be equivalent whether you put instrumentation or not. Now, the problem is that it's not typically randomized. So if a surgeon believes that you don't need to do instrumentation, maybe the surgeon was right. So I don't think we can learn from this that we just shouldn't put instrumentation and just do uninstrumented fusion. Absolutely clearly, there are so many cases where the patient is unstable, fracture, deformities, gross instabilities, where it won't work without instrumentation. So I don't think it makes a difference whether you instrument or not for the purposes of adjacent segment disease. And we know that adjacent segment disease can develop after non-instrumented fusion. And also after laminectomy without fusion as natural progression of the disease. Finally, there is no fusion like no fusion at all. Even in the presence of spondylolisthesis, the indication for fusion remains controversial. And we all know those two famous articles that came in 2016, one next to the other, one from the American group that includes Ogogawala and Benzel and Volker Sonntag and others, just really across the board, the leaders of US spine surgery. But ultimately, there was a very small group of patients, and they demonstrated that you need to add lumbar spinal fusion to a laminectomy. Otherwise, there is even higher rate of reoperation. But using a different inclusion criteria, not selecting for patients with spondylolisthesis, but just pulling them all together, decompression surgery with fusion or decompression alone, that didn't make a difference. But again, you could say reasonably that these two studies did not compare the same population. That really, to compare it properly, you needed to do what the American group did. But their group is relatively small, and they had a very high rate of reoperation. So it's just something that I like to mention, because we often are doing fusions with instrumentation for patients who may not need it and may do well without, and we need to be careful, because if we don't do an instrumented fusion, although degeneration at adjacent levels can happen, but it will happen, according to all the articles I cited before, at a lower rate. So what are the take-home messages? Well, one, radiographic adjacent segment disease can occur at L5S1 segment after fusion of segments above it. Clinically significant ASD can occur, but is less common. If the construct is long, clinical ASD appeared more likely. It may be advisable to add S1 and even pelvic attachment, or at least discuss the risk of further degeneration and further surgery with the patient. But I think it's quite safe, and according to some of the studies that we reviewed, it doesn't really harm the patient significantly to add S1. Again, maybe there is a higher risk of radiculopathy if you add the S1, but in the balance, I would say it's probably advisable. Probably it's advisable. Again, I don't think there is a clear consensus or it's entirely uncontroversial, but the prevalence of evidence is to add that. If the fused segment is short, and especially with a single level L4-5 fusion, adding L5S1 should only be considered if there already is significant stenosis and degeneration or borderline instability. If the level is healthy, adjacent segment disease develops very slowly, and it's probably not essential. All right, that's it. And thank you very much. Questions?
Ben, thank you so much for this really beautiful presentation. So it's really a difficult topic to discuss also. So when you're stopping at L5, you have problems like, as you mentioned, you have 50% degeneration at the L5S1 level. If you go to S1, again, you have some problems. And especially if you're doing adult degenerative scoliosis cases, commonly you have to go to S1, especially in the Russell type 1 cases, that's because the apex of the lumbar lordosis is at L5. So you have to do something, and I will say something different according to the literature. We have prepared some WFNS recommendation papers. Even in these papers, especially in thoracolumbar trauma, the literature says that fusion, and when they're comparing fusion and non-fusion surgery, they say that there are no difference. I'm talking about clinically.
Yeah.
If you fuse or if you don't fuse that part, clinically they are not, they don't have difference, but radiologically they have. And as you mentioned, all of the changes on the X-rays doesn't mean they may have symptoms. And another topic, as you have said, the PIC roads, and let's say the semi-rigid systems, maybe a solution for that, but we can discuss about it.
Yeah. Yeah, absolutely. Thank you very much. And I think that this is exactly, I completely agree. The comparisons that are being made are not always very, very valid, because they are not done prospectively, but they are done with surgeons having the freedom to decide how to treat patients. So we rarely see patients who are very grossly unstable and cannot stand up without stabilization, really not having stabilization surgery with instrumentation. We have typically we have patients who the surgeon decided that maybe they don't have to do surgery, or they don't have to put instrumentation, and then they are followed. And in many cases, looks like the surgeon was right. So it doesn't mean that from now on you should never put any instrumentation. It means that, well, maybe the judgment when left to the surgeon in those cases was reasonable. Zohar Gawala for many years, maybe more than 20 years, has been promoting the idea of surgical equipoise. So you would randomize patients in a study, but only among those where the panel of surgeons who helped in designing the study decided that there was an equipoise between the compared approaches. And then you compare it. Well, yes, then you can truly randomize them and they will not be lost to the study because something else was done or because the surgeon has a different judgment. But then you will only limit it to situations in which surgeons truly do not feel that there is a big difference between the approaches. So surgeons could be surprised, like they were surprised in the recent study that showed that laminoplasty, it was superior, surprisingly superior to laminectomy with fusion and anterior approaches for multi-segment cervical stenosis. It was a surprise. You can find certain things, but other things will be limited. Things that are controversial about topics such as fusing an unstable patient, that some people would believe that it's just inappropriate. Like you will never be able to truly compare a study because there won't be any equipoise, and maybe there shouldn't be equipoise. So that research in spine is very complicated to do, obviously.
You're right, Ben. Thank you so much. And if you have time, please stay with us. So we know where we have to go to S1 or where we have to stop. So is Richard here now? I think not. Any question to Ben? So I think we have to pass the other topic. Erkan Kaptanoğlu is with us. So he's going to talk about the sacral fixation techniques. Erkan Kaptanoğlu.
Yes. Can you hear?
Yeah, we can hear you.
Okay, thank you. Thank you for inviting me here. Hello, everyone. I'm going to talk about the, let me just screen. Share. Yeah. Can you see me, right?
So it's full screen now. We can see and hear you.
Okay.
Wonderful.
I'm going to talk about the sacral fixation techniques, a little bit anatomy, very short, and rationale, and sacral fixation techniques, and one case of lumbosacral fixation and iliac fixation techniques, and some tumor cases that we should go down. Actually, when I saw this picture, I thought this is more than I thought, actually. More ligaments that fixing lower lumbar to ilium and the posterior pelvis, as in anterior part. So we have a strong lumbar, sacral, and pelvic fixation. So muscles also support this fixation from the lateral, anterior, and posterior. So when do we go down to the pelvis to fix it? L5S1 listhesis, spondylosis, to correct pelvic obliquity, sacral distractions like trauma, tumor, and infection, or better to get a better corrected sagittal deformity imbalance, and to long lumbar instrumentation with past L5S1 surgery, disc degeneration, and stenosis. This is what literature says. So, what is the technique? This is how we enter, where we enter the S1 screw. It is inferolateral part, corner of S1 superior articular facet. This is the entry point, and then this is the direction most popular direction goes to anterior promontorium. If you pass the promontorium, it is called tricortical fixation, and we should go medially. I will show you the studies, because when you get older, your ala is getting weaker and weaker, comparing to body of S1. So there are some studies, they put screws lateral, medial, or straight into the sacrum, and then they get best results with one goes to the body and they enter the anterior cortex. Of course, those two screws are stronger. This is one of my cases. It's about 25 years ago. When I do operations, I had difficulty in entering the S1 screw because of the posterior iliac ala. So to direct the screw anteriorly and medially, I had to cut this posterior part of the superior iliac, posterior superior iliac spine, as you saw here. So we published it, and we found almost 15 to 20% of males have this problem. So this is another case. This is the entry point of S1 screw, and this is the iliac, posterior iliac spine, like a wall, obscuring the direction. And so then we cut the iliac spine, and then we can get a good diagonal direction to the anterior spine of S1 here, like here, and then this is screws goes to the anterior part. S2 screws and sacroiliac screws are almost popular. The starting point is S1 and S2 foramens, and then when we go laterally, and enter the iliac bone, it's sacroiliac screw. S2 alar screw also. For the iliac screw technique, we start with the posterior superior iliac spine. And usually we prefer to go just above the sciatic notch, because it is one of the strongest place in the ilium. Then we can put another screw to the top, to the up. There are some degrees that measured before, but I usually prefer to measure it before the operation. Okay, lumbar degenerative case. This is a case I use it in my presentation for just to give the idea. The patient has a positive sagittal balance. Tried to throw himself backwards, and then he get a flat thoracic vertebra, less kyphosis, but that wasn't enough, and patient bent his knees and retroverted the hips. So that wasn't enough. So patient has serious back pain, walking distance is low, bilateral root pain. This is the MRI. We saw here the foraminal stenosis L5S1 and the stenosis at L2. So we need to decompress the spine, and then for the balance, we need to put some extra instrument, and we have to do. We needed some osteotomy for the take the vertebra backwards and to give the lumbar lordosis better. So this is sacral chordoma case. This is 32-year-old engineer, computer engineer, difficult urination and erection problems, male patient. You see the tumor is here. The tumor, this is the CT scan, three-dimensional. Tumor occupies the spinal canal, and there is no actually way to save the roots in the sacrum. Actually, this is biopsies was a chordoma. So we did a total sacrectomy, L5S1. We cut because the tumor goes up to the L5S1. Here, fixing the ileum is depend on some factors, and the iliac resection is important. Yes, there are many good studies about the sacrectomy, instrumentation of sacrectomy. These shows actually on the studies quite similar results. Like this is like this one, that is what like this one. The more you put, the better, the slightly better results you can get. This is the idea. But factors that may affect the fixation, not the fusion, weight of the patient, bone quality, sacral bone left in surgery, quality and width of ileum, the leftover, distance between posterior iliac bones and lumbopelvic fusion. We have to do fusion. There are many product, custom-made products. So we remove the tumor of this patient. This is the chordoma. So we get surgical margins are negative. And we put screws like L3, 4, 5, and iliac screws. And the one graft between ileum, patient is good after the operation. Let's see. And this is after 6 weeks. The instrument is here. This is, we skip S1 because we don't have S1 here actually. For this kind of tumors, if we remove, this could be enough. I only changed one of the patient's rod in 2 years, and then he is good. This is a giant cell tumor. This is almost the same kind of implant fixation we have done. 45 years old mate. He has a diagnosis 5 months ago. He had an embolization 3 months ago. No good progress. Last 2 weeks, he cannot urinate and cannot defecate and had a slight neuro deficit. And he had a huge tumor here compressing the rectum, push anteriorly, and then bladder pushed anteriorly. We had very difficulty putting the catheter in here. So we embolized the patient again. We prepared like 45 units of aortic suspension, and then we start from the posterior. It was very bloody tumor. We remove posterior side by piecemeal, and then we start going anteriorly. We saw the rectum, and we went anteriorly and remove all the tumor, and then we save most of the sacral roots. One side we lost S3 and S4, but it didn't change didn't give us any nerve deficit. So we put almost the same instrument here, one iliac screw here, one iliac on the other. We put always a connector to close the posterior pelvis. This is why we do this, why we put very few instruments, because there are some pieces of sacrum, and this has a connection, a joint with the L5 vertebra. So this patient needed nothing after the operation. With the fixations, he was very good. So this is a sacral sarcoma. This is we are getting more instruments and more fixation in this kind of patients, because this is a sarcoma. Sarcomas are usually on one side. I don't know why. I saw a lot of left-sided sarcomas. So we plan to cut from here and from ileum, because there are tumor island in the iliac wings actually. So this is one side, left side up, and this is the sciatic notch here. We cut the ileum from the sciatic notch. We removed the tumor with the sacrum and ileum together. So we ended up with this hardware structure. We studied before the operation. We needed to get a T shape of connections. We don't have T shape. We didn't have T shape connectors here, so we have to do one, another, and then we turn. So we put two in one. One goes to almost into coxa, and here, and the other here, and the other. So we were very lucky in this case. We didn't get any infections, and in 2 weeks we sent the patient home. So pathology was sarcoma. This is another sarcoma case. This case is different because this is more lateral, and we have to remove more iliac bone. So biopsy was sarcoma also. This is one side, left side was up. And then we opened the posterior sacrum all the way to the coccyx, and then we cut the one side of the tumor, left side, because the tumor on the left side, we are going to cut the left side. And if we preserve one side, patient is going to be functional after the surgery. So we cut from here. This tumor went up to L5 vertebra. So we removed L5 and sacrum with the coccyx, and then with the muscular gluteus maximus muscle also. And so the pathology, sacral the sarcoma margins were negative, and here the plastic surgery helped us to put fibula, bony fibula graft, because we thought the defect is very, very big. So we needed a fusion for this case. So this case were also discharged. This is the last case. This is the first I'm presenting. This one had the tumor went up to the L4, but it was in the muscle here, in the paravertebral muscle, not in the bone. And then here it goes into the sacral bone, and then it is a huge tumor only on left side, on one side, and in the sacrum. Biopsy was sarcoma, and we removed the tumor. This is sacrum, all the sacrum, and this is muscle. Went up to the L3, I believe, L3. This is the pathology. This is the where the tumor is in the muscle, and this is the sacral bone with the tumor. This is chondrosarcoma. Surgical margins are negative, as we know. We have to be surgical margins are negative. So we, because we failed. In first case, we had to change the roads. So we thought we have to support from down to L5 to push the L5 up a little bit. So we hadn't. We asked producer to produce an instrument with T shape, and then they did it for us. And then we put it. And then this is also one side, and the other side, iliac screws. So we put a iliac plate to prevent when the patient gets up, to prevent posterior iliac opening. So after 2 months, a patient has get a loosened instruments like this, and then the instrument we put here with this angle was out and the screws were out, it was it was like everything was out. The patient was his mobilization was inappropriate actually, but we have to. So we saw the posterior iliac, posterior pelvic opening caused this, and then we make a revision. We put this instrument from posterior because this is more vertical now, and then we put 2 screws and we put a new stronger stainless steel plate here, so he's better so far. So the instrumentation safety for strategy for sacrectomy should be determined on a case-by-case basis. So we cannot estimate 100%, but there are of course some rules. What I've learned from sacrum for years, a spear screw must be strong, medially directed, and B or 3 cortical. Check closed posterior spinal iliac spine preoperatively. It helped you very much. It helped us. If it is lumbosacral fusion, interbody fusion is a must at L5-S1. If you're going to put screws S1, please do interbody fusion with bone or cages, whatever. For the lumbopelvic fixation, double iliac screws with double rods should be better. Total or extended sacrectomy, lumbar iliac bony fusion is crucial for long term. Thank you very much. Thank you.
Kaptanoğlu, thank you so much for this perfect presentation. So let me ask you a question. When you decide to stabilize the lumbosacral joint, which part of the sacrum, when you decided you have to need a fixation for that part?
What is your question actually?
My question is that in this distal part that you're removing from the sacrum, especially in the sacral tumors, okay?
Oh, for the tumors.
Yeah, you don't need to make any fixation. When do you decide that you need a fixation? If you let some part of the sacroiliac joint, do you consider?
Yes. According to the literature, if you can save 1 out of 3 of sacroiliac joints, you don't have to put the instruments. So I try not to put the instrument in sacroiliac in lumbosacral area if we don't need it.
So another question: when you're doing gray tumors like sacral tumors, you put a mesh to prevent the posterior part of the intestinal system. And do you have a trick? Sometimes there is a leakage there. It's not cerebrospinal fluid, or it's not a fluid coming from the intestinal system. When do you say that it will disappear in time to patient? What's your
okay?
Yeah.
There's a plane. There's a plane between the sacrum and the rectum.
Yeah.
If you keep that plane safe, you don't have to put any mesh. But if this is why general surgeon says, because of their experience. But if rectum, when you remove the tumor, rectum goes back, whatever you do. In any case, because the gas in the rectum and whatever, I don't know, rectum comes back. I like to put a mesh in between. Dacron mesh usually, or whatever, synthetic mesh. The fluids comes from the skin incision after the operation. It is usually seroma. Seroma is a lymphatic fluids sometimes starts after the operation. Even sometimes lumbar operations, we see seroma. It is not an infection. It is like a CSF. It is colorless fluid. So for the seroma, you have to compress the skin. You have to compress the wound to stop the seroma, because they called it as there is a lack of closing the lymphatic channels. So, but here you have a gap, you have an empty space, and it is very difficult to compress the skin. And skin is very, very sensitive to necrosis.
Kaptanoğlu, thank you so much for this valuable experiences. Suat Canbay from Turkey has a question to you. In a giant cell tumor, would you consider shrinking the tumor with denosumab treatment first, then surgery can be done more safely? You can also read it on the right side, on the bottom.
Okay. I can't read it, but I understand the question.
Okay.
We don't do any I don't know any study about the pre-op use of denosumab of giant cell tumors. Maybe Suat can give us some clues about this. If we can remove everything, so we don't give any denosumab. If we cannot, sometimes it goes to the coccyx, or it behaves like a malignant tumor. Yeah, we should.
Okay, Kaptanoğlu. And another question, I think Ben can answer this question from Turkey, Vehbi Gülmen. L5-S1 fusion may cause sacroiliac joint pain if iliac screws are added to L5-S1. Sacroiliac pain may occur in lower rate or vice versa. Ben? So Vehbi Gülmen is asking if the iliac screws are added to L5-S1 fusion, may we reduce the sacroiliac pain or vice versa?
Adding sacroiliac joints were shown to be affected, so they could degenerate faster if you add the L5-S1. So actually, the load hypothetically on the sacroiliac joints will increase, and in one of the articles that I cited, it was demonstrated. And then the authors there also added sacroiliac fusion separately, and apparently treated it well.
Any other question? So if you don't have any question, Yahya has a question, Kaptanoğlu. What do you think about autografts such as fibula graft or MTRA after sacrectomy?
Yes, it should be. It should be. Yeah, actually, we need something. We have L4, L5, L3, and the sides of these vertebrae, and cut L5, and then we have wings. We have posterior iliac wings. So we have to put in between. It is iliac bone is very fibula or iliac strip, like a patch, like a pan, okay, or finger. We have to put something like this, okay. In last two cases, we had a iliac strip bones like this, and when we put in between L5 and L4, between L5 and iliac and L4 and iliac, underneath the rods. So iliac fibula is a little bit long. You need the amount of fibula is a little bit long, so it is recommended to be the live fibula with the artery. So fibular graft taking is, yes, it is good, and we have an experience with this. But after 12 hours of operation, plastic surgeons takes the patient, and then it takes like 5 or 6 more hours. It depends the condition of the patient.
Thank you so much. So we can pass to the other topic now. We have another valuable friend here, Richard. Welcome.
Hi, Honor.
How are you?
Welcome. Thank you. How are you? So I'm
Everything
sorry,
fine?
I actually get out from the OR for a vascular injury during an ALIF, so I went to the OR, and this is why I'm late.
So
Sorry
how is
for.
the patient now?
He's okay.
Okay, fine. So Richard's topic is interbody fusion techniques. So we're listening to Richard. Please go on.
Can you see my screen?
Yeah, we can see it.
Okay. So this lecture is much more humble and modest than the previous one. It's just basics about when to go for anterior lumbosacral stabilization. So I started by just giving you my philosophy on this. I will always go anterior when I change the geometry of the disc, when for some reason I'm remodeling the spine, realigning the spine, and changing the geometry of the disc. I go to L5S1 disc is if the disc is high and mobile, and if I'm going to the sacrum, and also and it's more and more important is when lumbosacral lordosis is needed to avoid misalignment. So let me I go through examples. This is typical why anterior axis is important. Look at this patient. It's a very old case where we went only posteriorly with posterolateral, probably in the 90s, went for posterolateral fixation, patient translation, everything went fine, and you can see that it fails, and we know why it fails. It fails because the anterior support is not structurally good enough, and in this case we went first anterior and replaced the screw, and this was the end of the story. It's important also to look at this posterior axis for interbody fusion. It might be not enough to restore the good alignment, and you can see in this TLIF fixation here, the lumbosacral area is still misaligned, and you can see that at the level above start to have some listhesis as a compensation mechanism. So going anterior gives you more lordosis, and also especially in patient who needs lordosis, it's better than a TLIF procedure. So let me give you a typical example when and why I go anterior. This is a spondy by isthmic lysis at L5S1. The patient, this is a standing films, and you can see there is instability between L5 and S1. Let me take this. You can see here that on standing compared to lumbar MRI, the listhesis is more important, and we went anteriorly first after angio-CT here, where we can see clearly the arteries and the vein, and make sure that there is room for accessing the L5S1 disc here. And obviously, my main reason why I went anterior is to get not only better fusion, but the good alignment here, because this patient had a high pelvic incidence, like almost always in those lysis and those spondylolisthesis. So if I had chosen to go by a TLIF, I might be under-correcting the alignment and having some junctional issue. So two reasons to go anterior. One is better, larger footprint, better fusion, and also and mainly a better alignment. And you can see here this patient had no issues, no other complication. Postoperative was comfort. So we went from this to that. So the anterior lordosis is restored by interbody fusion devices, and then went posteriorly for stabilization. Let me show you how important is in terms of alignment going anterior. This patient comes to me, he's 60 something, comes to me for back pain, no sciatica, just back pain. We went through rehabilitation and still complaining. I told this patient, you know, let's realign first anteriorly because his pelvic incidence is over 50, and let's realign it anteriorly, and we'll go posterior in the second stage. You can see L45, L5S1. He's sportive, he's active, and I've done the angio CT here, and I decided to go by a lateral ALIF and OLIF in the same time. So this is what I've done. So I went in a lateral position, went for lateral ALIF at L5S1 here, and a lateral OLIF, pre-psoatic OLIF here to L45. So I was really surprised to see the impact of realignment. Look carefully at the patient before and look after. So look how the mechanism, compensation mechanism disappear. And mainly I want to show you the retroversion of the sacrum. This is before. Look carefully at the sacrum part here, and this is after. So you can see that from this to this, we get a better alignment and better comfort at the lumbosacral area. If we look here before, look where is the retroversion here, strong retroversion before, and if we look after the surgery, you see that the pelvic parameter and the mechanism of compensation went reversed back. So it is really a strong, I would say, features when it comes to aligning the lumbosacral area. Another example where anterior axis was the absolutely disruptive solution. This lady, she's overweighted and she had L4-5 problem here. L5S1 at the beginning was spontaneously fused. You can see here that there is no disc, mobile disc at L5S1. She went to a surgeon who does a full laminectomy and tried to fuse L4 to L5. I have no x-rays from that time, but the patient come to us after removing the posterior fixation. I don't know for which reason, and this is our patient now. So if you look here, what happens is actually by laminectomy and by trying to fuse here, he induced a kyphosis at L4-5. Again, L5S1 was already fused. And what happens to the patient to compensate, she dislocate L3, L4. So the patient overweighted. Her pelvic incidence is around 76, and he does a conventional laminectomy, try to decompress and to fuse. It fails, and we end up with the iatrogenic kyphotic lumbosacral area. If I go posterior in such a case, I'm not sure that I will properly align this. So what we decided to do is to go anterior first to L45, L3, L4. This is the right lateral positioning going left. This is my incision here. This is the iliac crest, and those are the two projection of the disc. So going OTP and ATP anterior to the psoas allows me to go to L45 and L3, L4, even if the disc is below the iliac crest. So this is a patient after you can see her previous scar here. So we went anterior, then posterior. And look at the results. I am almost sure that the anterior axis gave me the capability of restoring this alignment and getting, I've done a minimal invasive transmuscular fixation in the second stage. You can see the alignment here and before and after, before and after. So this is her post-op alignment, and you can see we still, it's not perfect, but at least we had an appropriate alignment at the lumbosacral area. And again, I'm almost sure today in my hands, going by a TLIF axis, even if I do osteotomies, I would say type 1 osteotomies, it won't, or type 2 won't be enough. Anterior save me and gave me the possibility of good alignment. This is a patient also who come to us for lumbar stenosis and severe back pain. This is his pre-op studies, and we went anterior for realignment and posterior what you call it, midliff fixation in a second stage. So again, it's a better, this is his post-op X-ray, and I feel more comfortable, and it's published and well known that anterior alignment generate better lordosis than posterior. So also anterior interbody fusion is an anterior structural support and might be needed every time we feel like the posterior only fixation is not enough. Look at this case here. We have done a VCR at a thoracolumbar area and realigned the patient. We were happy. This was in October 2012. We were happy, but look at the last disc. A few months later, it collapsed with some kind of dislodgement of the caudal screws. So we went from this to this without any breakage of the instrumentation. It was the interface between the bone and the implant fails because there is no anterior structural support. So we had to extend our fixation to the lumbosacral area. We decided to do that because a patient was on back pain and symptomatic. So from this to that, and we didn't went anteriorly here because the sacral fixation is strong enough, and we add the fusion. So this is here 3 point of fixation in the sacrum and ilium. And if you look to the CT scan, we have this amount of graft plus the screws in S1. You can see S1 in the also alar part of the sacrum and ilium part of the pelvis. So we had a strong enough fixation to avoid going anterior at L5 S1 because she's a bit old. So this is my main. Technically, I would not focus on this. We know that through a TLIF we can go posterior and place cage, but the restoring the lordosis is not enough. It's better to go either lateral interbody fusion or anterior interbody fusion. We won't go through why is this, why what are the difference between both. But we know that lateral interbody fusion today, especially the anterior to psoas, has became more popular, and we can even access L5S1. I always do angio CT especially in deformity, because you might have some anatomical difficulties, and it's important to prevent this by having this in advance. This is an ALIF. It's the best, I would say, anterior access, because you are purely supine. You can access anterior column directly, put large footprint, and stabilize the cage in the two body. This is the cage placed here. I recommend for anterior access, technically for the young fellows, and to read this paper. It's an old paper, but it has everything in terms of anatomy and in terms of difficulties for accessing the anterior spine, from vascular to the hypogastric plexus, everything is there. The lateral interbody fusion, it's I would say easier. Here, this is a patient that I showed you previously. So we've done 2 levels, and you can see that opening the external oblique, internal oblique, and the transverse gives you a nice access to the psoas here. And you can see on the psoas the genitofemoral nerve, and very quickly we can retract the psoas posteriorly and get access. This is a ureter here, get access to the L5, L4-5 or L3, L4 disc. So here you can see the sympathetic chain, the ureter here, the L4-5 disc, and on the left side, sorry, on the left side here, you can see the opening of the disc and the placing the cage. In conclusion, when to go anterior? I go anterior every time that structural support is needed. I go anterior when alignment is an issue, and I go anterior when I have a pseudarthrosis and when fusion fails. Thank you for your attention.
Richard, perfect presentation. So you're doing the anterior surgeries like you're doing anterior cervical discectomy, like it's very easy. So with doing the anterior surgery, you don't need any higher osteotomies. Am I right? So
if your disc is mobile.
yeah. So when you're comparing the combined surgery and the surgeries that you're doing with the posterior high-grade osteotomies, how is the rate of the complications
For
doing the surgeries from anterior? So we know that you have less bleeding because it's like doing something. If you don't have any complication about the bleeding, you have less bleeding. About the hospital stay, I think you have less hospital stay.
Honor, you're talking about deformity cases, yes?
Yeah.
Yes. In deformity cases, my main issue is to plan my anterior alignment. I don't know if you have any thought about that, but when I have a Cobb angle, for example, for 10 with mobile lumbar area, I go anterior for realignment and go posterior percutaneous. But I cannot predict how much I will be good in terms of alignment by anterior axis. I like to have void in the disc. If I have air in the disc or gas in the disc, this is for me something that that push me to go anterior because the disc is mobile, empty. I go to the anterior if the cob is not severe, cob angle, and I go anterior if the posterior facets are not hypertrophic and locked. And usually I go in the concavity of the deformity. But again, I have much less complication for anterior access than from posterior access with osteotomies.
Yeah.
I don't have a percentage to give you, but my main failure in anterior first is not aligning properly and enough the coronal views of my patients.
So another question, I think you were using the CALPS. So you're measuring everything on the software, am I right? So how can we connect with them? I have written them a few times
Yeah.
on emails.
Honor, you will have a better one soon.
Yeah. Okay. So Corina is with us.
Yes,
Hello,
hello.
Corina.
I'm sorry, I put the wrong time zone in, so I came 1 hour, but many apologies. But I did get the end of, some of your talk, Richard, which was really, really good. And I too am a very big fan of the anterior approach, so I'm glad that you spoke to those benefits. A couple questions that I had about that. One of them is actually a question from the chat. One of our participants was asking about whether or not you need and use vascular surgeons for your A-lifts. So I thought I would ask that question first for him.
No, I'm a believer that first we have to have the vascular surgeon ready somewhere. And we have a convention, we have a contract with our vascular surgeon that every time we go anterior, they know that we are in such a surgery, and they came to us immediately. But having an access surgeon every time you go anterior would be from our facilities here, even with a huge hospital, it's not so convenient. So, and I believe also that the spine surgeon has to access himself all complex areas. Um, so in our institution, first, and even in France, there is no anterior surgery if you don't have vascular facilities. Second, my vascular surgeons are ready to come if I have, and in 15 years, we had them 3 times. Like today, for example, I was doing my one of my senior fellow was doing an ALIF, and he calls me because he had some minor bleeding, and this is also I arrived late. Um, so no access surgeon. The access surgeon is a spine surgeon.
Interesting. I would say so at Stanford and in the United States, we pretty much always have access surgeons. And so, that kind of follows up. You were showing how you do the angio CTs, and we pretty much, never get those. And we, kind of routinely use access surgeons. I'd say also, I think medical legally kind of in the United States right now, if you don't use an access surgeon, it's a bit of a problem for us.
Oh
But
yeah, I
that's,
didn't know
yeah.
that.
Yeah, that's why I think it's always very
But
interesting to meet people internationally and see how things are in different countries. But yeah, I
yeah,
think given the state of things in the United States right now, you're very hard to defend yourself if you have a problem with an ALIF
yeah,
without a vascular surgeon
yeah.
doing the access.
We might be in this situation if I do surgery somewhere where there is no a vascular surgeon. But as far as vascular surgery is in your institution, you can go by own. And there is it looks uh, minor, but it has its importance. In the States, you can code your surgery and take into consideration that you have an access surgeon. In France, if you get an access surgeon, he has to be for free almost, or get a part of your fees. So it makes it probably more difficult in private practice to get an access surgeon every time.
Yeah, well, they do take a part of our fees. Our fees go down about half.
Ah, okay,
Yeah, yeah, yeah. We share
good.
them. Other than so what you mentioned you with the angio CT, obviously you can see, the blood vessels themselves, but how much do you take into account, for example, calcifications, right? Because those we can see a lot on the x-rays, and sometimes you have your older patients and you see they're completely atherosclerotic and calcified. Does that push you one way or the other? Since you're your own access surgeon, I ask because for us, we don't get it. Our access surgeons pretty much go regardless of what the anatomy is. So I was just curious about that.
Yeah, it depends how important is to go anterior. If you're hesitating and you have big osteophytes, osteophytes are our enemies because it's stuck to there is some kind of inflammation and the veins are very stuck to the osteophyte. And every time we had venal issues, it was in this situation. So if I'm hesitating and my anterior axis is minorly better, I would go posterior. But if it's important, for example, if you have a patient who had many surgery posterior and your only option is anterior, I will tell my vascular surgeon that I'm going in such a case, and either he will come and have a look once I'm on it, and especially if you want to mobilize, for example, the iliac veins, or I do it by myself. Yeah, but it's not an absolute counterindication, but you have to look at it and prepare yourself that you might have some adhesions.
Thank you. There's a
Corinne, we have lots of questions to Richard. You may ask them. It's written on the right bottom here.
Yeah. So one of them is if you use neuromonitoring when you perform your lateral.
No. Because I'm anterior to the psoas, I would use intraoperative monitoring if I'm transpsoatic access, and I've done lots of them. But one of the advantage of ATP, OTP, ATP anterior to psoas is that you don't get close to the get close to the lumbosacral plexus, so you are away from the lumbosacral plexus, and I never had any injury of the lumbosacral plexus by going anterior to psoas.
And along those lines, someone was asking about femoral nerve stretching during psoas mobilization.
Yeah, I know because I go gradually to mobilize the psoas, and I stop once I get enough space for L4-5, because the femoral stretch, it's at L4-5. Do not break too much your table first, and then do it gently with peanuts, retracting the psoas posteriorly. You have psoiatism, you might have some psoas pain when you flex your hip, but I never had any femoral nerve injury.
And someone also wants to know about superior hypogastric nervous plexus injuries as well.
Yeah, this is I always tell my patient, inform my patient, get their consent about retrograde ejaculation, etc., etc. In ALIF, uh, in lateral, there is no issue for that. For the ALIF, the risk is around 3%, and I always tell my patient that you might have, in 3% of the cases, some retrograde ejaculation. And if I feel like they are hesitating, I would not go anterior. I said, it's and if they accept, I go anterior, and technically it's always a blunt dissection. And this is also important, because if you ask an access surgeon to go to the promontorium, to the lumbosacral area, they expose with monocautery. They took a monocautery and do the hemostasis with, and this is very risky for retrograde ejaculation and for hypogastric plexus injury, unless your access surgeon is familiar as you to the anatomy, etc., etc. But if you take any general vascular surgeon, because they are used to go lateral for vascular surgery, they use monocautery. So no monocautery. It's always a bipolar. I would almost never cauterize till I get exposure, naked exposure, very sharp exposure of the lumbosacral area by using blunt dissection, and that's it. So in my series, I get probably less than 2%. One was a granuloma infection, so by posterior, we went to debride him anteriorly, and it was obvious that he will get retrograde ejaculation. And I told him before he was old enough to accept this issue. And the other one was a patient in the series of lumbar disc prosthesis. He was young and he was 36 and had not complete retrograde ejaculation, but hypospermia. I don't know what you call it. It's a kind of decreased amount of ejaculation.
So I'd like to thank Richard, Ben, and also Captain Ola. I think we had listened very beautiful, very valuable talks, and we have beautiful discussing. Any other questions?
I have one.
Please.
Richard, it's a nice presentation, really, but you are a person doing most of the interbody fusions with anterior approaches. Am I right? Do you ever use TLIF?
Yes,
sometimes?
yes, of course, of course. Yes, yes. But I use TLIF for
When?
I use next time. Ask me to talk about TLIF, especially since I have the robot, etc. It's so easy now. I use the TLIF when my pelvic incidence is below. It's normal, like around 50. I go TLIF. I go TLIF when patient is old and I don't want to play with the vessels anteriorly. And I do my interbody fusion when I'm doing a deformity by posterior access where osteotomies are done. So I do my osteotomies and place the cage also. But I agree with you, and this is why you have this impression. I'm fan of anterior access, and my TLIF procedures drops down by, I would say, by 70%. In 10 years ago, we were all of us, we were doing so much TLIF or PLIF. And when I discover the technical, when I mastered technically the anterior access, I prefer going anterior combined with posterior if needed. But I still do, of course, TLFs. I still do also asymmetrical pliffs. If I have to correct coronal issue, I might. I've done this last week where I place pliff cages on the collapse part of the disc if I have a lateral collapse. So I learned this from Daniel Chopin, and I still do that.
Thank you. Thanks a lot. Great talks, really.
So I think we have to finish our meeting. Again, thank you so much, Richard, Ben, and Captain Olu. So hope you're going to see us in the next meeting. Thank you so much.
Thank you. Pleasure.
Yeah.
Thank you a lot.
Thank you so much.
Bye. Bye, Corina.
Goodbye, Corina. Goodbye, Richard.
Great to see you all.
Wish to see you again.